Good afternoon, everyone. Thank you for tuning in to the Youth Mobile Crisis Intervention Services webinar. This is the first webinar of 2-in-1 Connecticut's winter webinar series. The next will take place next Tuesday, February 26th, and will focus on the Fatherhood Initiative. My name is Annie Scully. I'm a Community Results Center employee here at the United Way of Connecticut. I'm excited to introduce our three presenters this afternoon. Arnie Trezenti, who is the Supervising Consulting Psychologist with the Department of Children and Families. Amy Evison, who is a Service Director at Community Health Resources. And then our very own Sarah Camerata, who is the Youth Mobile Crisis Program Manager here at 2-in-1 Connecticut. Thanks again for tuning in, and I'm going to turn the mic over to Arnie.
Good afternoon, everyone. Appreciate you joining us for this webinar. This is Arnie Trezenti with DCF, and just want to kind of first start out by giving you some information about our name. You might know us, many of you, as Emergency Mobile Psychiatric Services. That's what we were called for a number of years. And until last year, we ended up changing the name based primarily on input from the federal government saying that we should keep the name consistent with the terminology that they were using. So we decided to change the name to Mobile Crisis Intervention Services. And you'll be hearing us use the term mobile crisis, but we apologize in advance if you hear us lapsing into the term EMPS occasionally. What we did with the name was we put the EMPS in front of the Mobile Crisis Intervention Services as a label just to help folks not be confused that they're two different services. So that's why we have the EMPS Mobile Crisis Intervention Services label for you. Now, what is Mobile Crisis Intervention Services? It's a statewide service. It's a mental health, behavioral health service that's community-based and family supportive that provides a clinical intervention for children and adolescents and their families that are experiencing a behavioral or mental health crisis. We'll go into more detail about the specifics of this, but more generally, what the service provides is a stabilization of the child so that they're out of the crisis and no longer in crisis. Then, if there's need for follow-up support, we will provide additional visits. We can actually visit for up to 45 days, so it's not just a one-and-done service. We can be involved for longer term. And if the child and family needs additional services and they don't already have a connection to behavioral health or mental health services, Mobile Crisis will help connect the family and the child to services as well. So, Mobile Crisis serves every child in Connecticut from age 17 and younger, or 18 years of age if they're still in high school. And as I indicated, Mobile Crisis is available for all children in crisis, including children who already have established services in the community. If a child has an individual therapist, or if there's a family therapy involved, or if the child's in an after-school program, that doesn't preclude them or stop them from having Mobile Crisis services. If the child's in crisis, we will respond, and then the Mobile Crisis clinicians will follow up with the service provider that the child and family already has to brief them and provide information on the intervention that was provided. And anyone can call on behalf of the child. We have schools calling in, we have pediatricians calling in, the emergency departments call in, other family members can call in. There's no specific identification of who can call in for Mobile Crisis Services. Anybody can call on behalf of the child as needed. And the way Mobile Crisis works is it'll go to the child wherever they're located. And that can be in their home, at school, in a doctor's or physician's office, in the emergency department, or any other community setting. There are a few exceptions, and that's based on treatment settings where there's a high level of supervision and clinical services already in place. So we don't go to residential treatment centers, we don't go to subacute units or inpatient units with Mobile Crisis, again, because they already have pretty sufficient services to deal with the crisis. But outside of that, we will accept any call on behalf of a child in crisis. Now we have 6 Mobile Crisis providers that cover the state, and they totally represent 14 different offices around the state. And every town in Connecticut is covered by Mobile Crisis. So there's no exceptions to services throughout the state by mobile crisis. And as you can see, from the 6 providers, Child and Family Guidance Center serves the Southwest area, which is basically the Fairfield County area. Clifford Beers serves the New Haven area. Community Health Resources serves the central area, which is the Middletown area in general. United Community and Family Services serves the eastern area, which is the Norwich-Willimantic part of the state. Wellmore Behavioral Health serves the western area, which is Waterbury, Torrington, and Danbury. And Wheeler Clinic serves the Hartford area of the state.
Hello, this is Amy Evison. I'm from CHR, and I'm going to help define what is a crisis. So essentially, the crisis is defined by the caller, not the mobile crisis team. And we don't have a predetermined criteria that qualifies, so you should always call, especially if you're not sure. We would want to hear from you. The mobile crisis team could be face-to-face, or it could be a phone call. That's also up to the caller. And it's really contingent upon the specific situation at the time of the call. So if it's during mobile hours, we're certainly available to come if that's what you're requesting, or you can talk to us by phone and consult about whether or not you'd want somebody to come out and see the child. It's important to say that these services are confidential and private. So who provides it? We are highly trained mental health professionals, and we could be a clinical psychologist, a clinical social worker, a marriage and family therapist, a professional counselor, and or an alcohol and drug counselor. And the clinicians are licensed and some are license eligible. All the clinical staff receive training. Initially, there's about 11 to 12 specific courses that are required in the first year that they're working for the mobile crisis team, and they gain specific skills around managing crisis. In terms of cost, there is no out-of-pocket cost. We will request insurance information and bill the insurance company, but we are not going to charge any fee, whether the claim was denied or even if there's a copay or deductible. So the crisis service is essentially free to the family, but we will use insurance information when that's available. That is not a deterrent to use the service and should never be. There's also no cost to the school or another agency or doctor who might call on behalf of the family. They're not charged for making the referral. We don't want financial reasons to be a barrier to the service.
Hello, this is Sarah Camerata, and I'm going to talk with you a little bit about how to access mobile crisis services. So in order to access mobile crisis services, you're going to dial 211 on your phone. Many of you know 211 as the info line in the state. We also have adult crisis lines, and we serve as the intake for youth mobile crisis for the state of Connecticut. So in order to access youth mobile crisis, you're going to dial 211 on your phone, and then at the prompt, you're going to press 1 for crisis, and then 1 again for youth mobile crisis. The prompts will not change and have not changed. They are to dial 211, 1, and then 1. Please do utilize those prompts versus any other prompts to make sure that you get the quickest service possible for the youth that you're calling with concern about. All 211 calls are handled by a single statewide call center implemented by 211 for a seamless coordination with the mobile crisis service providers. We're able to quickly gather a little bit of demographic information, do an initial safety assessment, make sure that the situation is safe enough to pass on to the provider, and wait for a short bit of time for the provider to get there. And then we'll put the caller on a quick hold, call over to the mobile crisis provider, give them a little bit of initial information, and pass them over to speak with the caller themselves. The mobile crisis clinician can respond to the location of the child within 45 minutes. I like to say 45 minutes or less, it's like a pizza. They can respond within 45 minutes for an immediate mobile assessment. When is mobile crisis available? Calls can be made to the Mobile Crisis 211 call center any time of the day, any day of the week, weekends and holidays included. We never close. Mobile crisis mobile hours are from 6 o'clock a.m. to 10 o'clock p.m. Monday through Friday, and then from 1 o'clock p.m. to 10 o'clock p.m. on weekends and holidays. During these times, trained mental health clinicians are available to go to the child's location for a face-to-face evaluation within 45 minutes. In addition to having mobile hours, where a clinician is able to go out and meet with the child for a mobile assessment, we also have clinicians available during what we call non-mobile hours to immediately talk with a youth and a family for phone stabilization when mobile crisis is not immediately mobile. They are, again, trained mental health clinicians, either licensed or license eligible. They're able to evaluate and stabilize the crisis situation for the child by phone during non-mobile hours. And then there are a variety of response options. The majority of the time we are able to stabilize the situation right there by phone, and maybe nothing else needs to happen. There's also the option, if we need to, of calling for an emergency response. Typically, we try to have our own response first through phone stabilization. We also have the option to work with the family to make a safety plan, stabilize the situation for the time being, and then schedule for a mobile crisis evaluation when mobile crisis is again mobile, either at 6 o'clock in the morning or around 1 o'clock on a weekend. Those are all, options that the mobile crisis clinician who is talking with the family or the child during non-mobile hours can work with the family around. We will always go with the safest and most comfortable situation for the family. So when to call mobile crisis? Call mobile crisis when the child threatens or is at risk for suicide, the child threatens or is at risk for violence, the child has been victimized or traumatized, or you believe that the child has been victimized or traumatized, harm is likely to occur without immediate assistance, the child is behaviorally acting out or out of control, the child is in distress or uncommunicative, the child is depressed and you are worried, or the child is having another behavioral health crisis. Typically, providers that are close to the child or family members who are close to the child, when a child is acting in a way that they don't typically act. And when you should be concerned because you are the closest people to the child. Call 211, press 1 and then 1 for mobile crisis when you are considering sending a child to the emergency room for an evaluation, but the child is not in need of an immediate intervention, meaning you can wait for a short time for a mobile crisis clinician to get there. You do not need a 911 response. Or when you can't reach the child's behavioral health service provider during a crisis, say if the child has ICAPS, they're not available during the crisis, typically you would reach out to them. You can reach out to mobile crisis in place of them or in conjunction with them. Call 211, prompt 1 and then prompt 1 for crisis when you have already called the police. Calling the police does not exclude a mobile crisis response. The only thing that would exclude mobile crisis from responding is if the situation is too immediately unsafe for them to do so. But the police often make situations that could possibly be unsafe much more safe for everybody. Mobile crisis can respond to a situation with police assistance or after the police have stabilized the situation. You can call the police first, tell the police that you're going to call mobile crisis as well, and then call 211 for a mobile crisis response. Just let the 211 contact specialist know that the police have already been called and they're en route, and we would be happy to come out.
So to finish around the police calls, call when a child needs an immediate police intervention, meaning if there's weapons involved or a serious assault that really requires legal attention. Call if the child needs immediate medical attention, an overdose, currently intoxicated or seriously injured. That means that the child needs an ambulance in order to address their acute medical needs. And mobile crisis can respond to a situation with police after they've stabilized. So essentially, there's a role for both of us. As we said, contacting the police first for safety reasons doesn't preclude you from calling mobile crisis to provide the mental health evaluation. So we both have a role. So there's a few types of responses for 211 mobile crisis. The first is mobile, which is the most immediate and our fastest response. Essentially, as we've said before, we will meet the child in their home, at the school, or in the community within 45 minutes of receiving the call. We will meet them wherever they are. So we will go to them. The second type of option is deferred, which essentially just means at a later time, which could be within a couple hours, sometimes even within a couple days of the initial call. More often than not, these are scenarios where the child is not in an acute crisis that requires a 45-minute response, but certainly needs an evaluation sooner than they could schedule an appointment with another provider. If it's beyond that, we believe that you may want to contact a local provider. Essentially, anything over 5 days is typically a scenario that you should schedule an appointment for. The third response option is non-mobile, which means that we're not going out to see the child in person, but essentially it's phone support that's available to the caller. And that is available 24 hours a day, 365 days a year. Essentially, you can always speak to a live person at 211 who will provide you with assistance. And within that non-mobile response, the mobile crisis team could actually go out later. So if you called during our non-mobile hours, it's important to say that you're requesting a mobile response when the team is then available within that 6 a.m. to 10 p.m. time frame during the week, or the 1 p.m. to 10 p.m. on weekends. So you can call outside of our mobility and get support, but the face-to-face response is during our mobile hours. So what happens when the mobile crisis clinician comes out? Essentially, we're addressing the child's current crisis and helping to de-escalate the situation and help the child and support the child. We will develop a crisis safety plan, which is available for the child and family to keep, and we also keep a copy, and it's something that we develop with the child and family together. And then we want to connect the child. That's really the most important linkage that we offer to another mental health provider or resources in the community. So providing that linkage and support is really what we're doing beyond the acute crisis. We are going to collect clinical information on the child and formulate an assessment and a safety plan and recommendations. So the evaluation that we're providing, is lengthy and does require information from the child and the family. And then we also provide the stabilization that we've heard before. So beyond that initial crisis visit, we will meet with other members of the team and the child and family for up to 6 weeks, really as needed or requested. Services, not only the initial crisis, but the stabilization as well.
So what happens when a 211 clinician talks on the phone with a child? Outside of mobile hours or during non-mobile hours, or even during mobile hours when there is just a non-mobile response requested, a 211 clinician is available by phone to address the child's crisis situation. The goal, again, is always going to be stabilizing the child and stabilizing the situation right there in the home. Typically, we can do that by discussing options with the caller, speaking directly with the child, directly with the parent, directly with the people in the home who are affected, and dealing right there with the crisis situation. We're looking to sort of immediately intervene, help the child utilize their coping skills, help the parents utilize strategies in order to help the child utilize their coping skills, and help the situation become as stable and as safe as possible. We speak, again, directly with the child if it's appropriate. We discuss steps with the callers in order to make a safety plan to address the crisis right there. We arrange to have a mobile crisis clinician go to the child's location during mobile hours if it's non-mobile hours, if that's needed, and we can really help you make that decision if you call during non-mobile hours. Maybe a parent is really on the fence about whether or not they want to take that step to have a mobile crisis clinician come out. The clinician speaking on the phone can help the parent make the decision that is the safest and best for them and best for the family and for the child. Identifying other resources in the community to help and support the child is also an important part of what we do. What are the supports that you have at 8 o'clock in the morning on Saturday morning that can get you to 1 o'clock, 1:30 on Saturday afternoon? Can you call grandma who lives down the street to come and help because the child responds really well to grandma or grandpa? Can dad come and help the child? Is there a neighbor that helps? What can we bring in as a support that we can identify to help this situation stabilize until a clinician can get out there and do an in-person interview?
Now, Mobile Crisis really works to collaborate with a number of community services that are provided. We've already given you information about the collaboration with the police. We'll give you other information on other kinds of collaborations. But I want to highlight the collaboration that we have with the schools. As is obvious, children are in school. They spend a lot of time in schools, and schools are responsible for educating the children, but also for managing their behavior and helping them in a variety of ways to be able to be successful in the school and outside of the school. As we know, sometimes children have conflicts and issues in schools, and they will have crises in school, and Mobile Crisis is available to work and address those crises in school. Now, it isn't just something that we've decided to do. There's actually legislation, Connecticut Public Act 13178, that has clearly outlined that Mobile Crisis will develop memorandums of agreement with every school, charter school, technical school in the state to establish a collaborative working relationship to support the school and most specifically the children in the school. We've actually completed almost 100% of the memorandums of agreement with all the schools in Connecticut. We just have a few outliers left. And as a result of those memorandums of agreement, prior to really getting those in place, our #1 referral source was families and parents But after getting the memorandums of agreement, our number one referral source now is actually schools, which kind of reinforces for us the value of having established that collaboration and that supportive relationship. And really, the memorandums of agreement are established, as you can see, to improve coordination and communication around mental health services for children while they're in the school, and to support the school and the parent in planning for any appropriate follow-up services for the child. Now, in terms of how mobile crisis works with the schools, we obviously will respond to calls from the school, from school counselors, from school nurses, from school psychologists, from vice principals and principals when a child is in crisis. And what we will do is we will go directly to the school when the school calls, and we will engage the child and work to de-escalate the situation and keep them in the school, which is a very important goal of ours, and help them to return to the regular routine within the school and not be removed or sent to the emergency department, which is, again, a very important goal for us, to not have the child removed from the school for any particular reason. We'll also work with the staff to provide consultation around how to work with that child, and that will include, as has been mentioned, the development of a safety plan for how to ensure that the child doesn't go into crisis again. So we do a lot of work specifically around incidents where children may have a crisis in the school, responding directly to the school. We also work with the school in other situations, which unfortunately we really hope we didn't have to work with, but they do occur, situations where there may be an untimely death of a child or a suicide death of a child. These are events that really are obviously traumatic for the family involved, but also for the school community, and the school community involves both children and staff and other members of the community. So whenever those events occur, we are prepared, we're trained, and we have a lot of resources to bring to bear to supporting the school and in the ways that are needed to get through the crisis initially and also to follow them subsequently. And that involves, as needed, meeting with the children, either individually or in groups that may be feeling overwhelmed by the event, talking to the staff and working with them, meeting with the family that was involved, and even meeting with folks in the community to address that. And in that regard, we also will work with the adult mobile crisis teams who may be brought in a situation where school staff and adults in the community need additional support. So that's how we work to support the schools.
So as we heard, school staff can request a mobile crisis evaluation to the school, and it is expected that the school will contact the parent or caregiver first. Often 211 will ask that question if the parent's been notified, but we will still see that child in the school even if the parent or caregiver cannot be contacted because of the acute emergency that the child is currently in. So we can go if the parent can't be reached, and we are available to work with the school to do crisis planning around a specific student. However, if a parent or legal guardian refuses the crisis service, then mobile crisis isn't going to provide a direct assessment or evaluation of the child, but we could still work with the school. And often what we find is even if a parent initially declines, the mobile crisis team will make an attempt to contact the parent directly in order to arrange the possibility of seeing the child at a later time or even outside the school. That often we find if there's a reason why the parent is refusing for the child to be seen at the school, sometimes they will consider having the child be seen later or in a different location. So we will still go out to the school, but consent is requested of parents, and unfortunately declining the service is something that can happen, and it's something that we often try to work through as a priority to get that child's their needs met. So school staff can coordinate with parents to have the mobile crisis team go to the student's home after school. We prefer that you would call and request a deferred response, as we heard earlier. And those requests in coordinating something later through a third party are a bit trickier. So we also expect that the school will be in contact with the family in relation to the request for a deferred response. We don't want to show up unannounced to someone's home because they may not be there sometimes, or they may not understand why we're appearing. So the school can request a deferred response for later, but that requires more coordination between the school and the parent.
And Amy, correct me if I'm wrong, you will always have to reach out to the parents in a case like that to ensure that the parent is willing to have mobile crisis come out to the home.
Right. Like we are not going to see a child typically alone with no adult. That wouldn't be appropriate, even for an older child, that we wouldn't expect them to allow us to come in their home or participate in an evaluation without an adult present, and we prefer a parent or guardian present. So we do coordinate a deferred response to the home in more detail than we would a deferred response to the school or where other adults are present. So, in terms of mobile crisis in collaboration with emergency departments, the rates of emergency department visits for mental health issues have increased significantly over the past 10 to 15 years, contributing to gridlock in the emergency departments. So mobile crisis is available to divert some of those children from the ED, and certainly those that don't meet the thresholds for inpatient services, that many of those children who show up in the emergency department are often sent home, and sent home with recommendations, but not the follow-up that the mobile crisis team could offer. So we really see ourselves as a mobile emergency room to some extent, really a service that's cheaper in terms of the dollars spent towards the service versus the dollars spent for an emergency room visit, but also providing a more direct and immediate response. We will see a child within 45 minutes, where many children can sometimes wait for hours and sometimes more than a day in order to be seen and evaluated. So mobile crisis can certainly see children quicker and sooner than an emergency room at times, especially this time of year. Summer's a little better, but during the school years that you could wait a very long time in an emergency room. So when a child's in an emergency room, for mental health issues, the mobile crisis can go to ED. So that's another service that we provide. We bridge services for children who've already been evaluated in the emergency room, but it's been determined that they can be released back into the community. So each mobile team has affiliations with their local hospitals in order to provide those bridging services and provide follow-up to those kids who are not going inpatient. So we are trying to divert children from the ED and into the appropriate level of care. They're not the best environment to provide mental health care. And some hospitals do have, like CCMC in Connecticut, a sort of separate location for children with mental health issues to be evaluated and even wait, but not all hospitals can do that. And so children would be exposed to medical crises of other children and adults that could be traumatic and overwhelming for them. And hospital staff may have limited knowledge about community mental health services and options, meaning within the mobile crisis teams, we often know about the services that are available, if there's wait lists, what type of insurance certain programs take, the age restrictions. So there's a lot that the mobile crisis team knows about making the appropriate referral in a timely way. And unnecessary ED visits do interfere with their practice. So oftentimes hospitals will go on diversion when they have an overload of individuals in their emergency department, and they know that they can't provide the immediate care that's necessary for their most acute patients. And so many emergency rooms welcome the use of mobile crisis services to help filter through those children who can be served in the community. So, as we heard earlier, mobile crisis can collaborate with police in joining them at a child's home or a community location to provide mental health assessment intervention. We can also provide assessment intervention as an alternative to police involvement and arrest as appropriate. There are a lot of kids who were seen as juvenile offenders who may have committed illegal acts or had assaultive behavior, but we would like to view those situations through the lens of a mental health issue as an opportunity to help divert those children from the juvenile justice system to really services and supports that can help them, reduce the incarceration of children and certainly the long-term impact of being incarcerated even as an adult.
And Amy, I want to add, it's a much less overwhelming response for mobile crisis to come to the home and intervene than, say, a police officer and an ambulance. You know, in the past, prior to mobile crisis existing, if somebody were to call for support for their child whom was struggling, the option would have been a police response and then an ambulance response. Now, as long as safety can be maintained for a short period of time, the response is much more appropriate to the need and much more and much softer all around.
Mm-hmm. Right, like there are too many children who are arrested by the police when a mental health assessment and evaluation should be the priority. They're just at increased arrest for juvenile justice involvement, and so one of our missions is to identify that population and work with the police to reduce unnecessary arrests. And police will tell you that they contact us themselves in order to get the mobile crisis services, as opposed to general police, business, that they need to take care of, that they need to go out and get the bad guys. They don't necessarily need to make decisions about the mental health of children in their community. Their job is to help connect us to those kids whenever possible. And so that's one of our, goals and missions of the service as well.
And they welcome that support, they really do.
Okay, I'm going to address some of the overall goals of mobile crisis. And as we've already kind of shared with you in a variety of ways, one of the goals is to be highly mobile, to actually go to where the child is, wherever they are in the community, be it their home, the school, in a physician's office, in the emergency department. We do a lot of work in support of the emergency department, as you've already heard. But wherever the child is, we will go there. And I just want to give you a little anecdote to kind of illustrate this. And we had a call for one of our teams. A mother called into mobile crisis, and she was in a crisis. And again, to reiterate what we define as a crisis, the caller defines the crisis. We don't define the crisis. She called in, and her crisis was she was in Kohl's department store, and her son had taken the family keys, that included the car keys, and had hidden them somewhere in the store, and was refusing to give the keys back to the mother. Mother was at her wit's end, didn't know what to do. She knew there was a service called 211. She called 211, and we responded. We went to the Kohl's. Our clinician went to the Kohl's department store, and was actually quite adroit and skilled, and was able to talk to the child and get the keys back for the mother. So now, some folks might think this might be sort of on the borderline of what would be an appropriate use of 211. In this particular case, again, we had a very skilled clinician. As part of the clinician's assessment of the family dynamic, the child and the mother, determined that this just wasn't a one-off situation. This wasn't something that had just occurred, that there was obviously some history and some issues between the mother and the child. So the clinician skillfully suggested and then connected the family with services in the community. So that's one of the benefits of having an open sort of criteria for what is defined as a crisis. Sometimes a crisis doesn't look like a crisis at the front end, but when you kind of do an assessment and look at it a little more closely, then you see that there's a reason why someone is calling 211, and it may not be obvious at the front end, but then it becomes more obvious at the back end. And our being responsive in that way is one of the things that we do. And again, in terms of being responsive, we do try to get there within 45 minutes. We have a criteria for that. Now, reality is we expect at least 80% of all the calls to be responded to within 45 minutes. And the reason we have that sort of criteria is we understand that sometimes there's a high call volume and people may be tied up and can't get out within 45 minutes. But also there may be issues around geography, where there may be a longer distance to travel to get to a home or where the location of the child is. So we build in a little extra time, but we have exceeded the 80% benchmark significantly for a number of years now. So we've been very responsive in being able to achieve the 45-minute or less criteria. And we establish convenient hours. Now, as we let you know, the mobile hours are from 6 a.m. to 10 p.m. And the reason why we established those particular hours is because we've looked at the call volume of when the most calls were coming into 211 in terms of crises that parents and other callers were calling in about. And we saw what would be the most appropriate, most useful times to have a mobile response. And the data basically told us it would be 6 a.m. to 10 p.m. Outside of those hours, the call volume drops off significantly. And whatever comes in at that time, as has already been shared with you, is handled by our really skilled 211 clinicians online. And if mobile crisis is needed subsequently, then they can be activated once mobile crisis is available. But we try to make the hours of mobility available to be as convenient as possible. And outside of that, mobile crisis 211 is always available. One of our goals is to reach everybody who needs a service. This past year, state fiscal year 2018, we had the highest call volume of any year that we've ever had mobile crisis. We had almost 20,000 calls to 211, which is quite a high volume. We're really quite pleased about that, and we're actually on track to exceed that number for this current fiscal year 2019. So we are achieving our goal of being able to reach whoever needs the service.
So you are utilizing our services, and we say thank you for that.
Yes. And as part of our service, one of our goals is we do a lot of outreach. Obviously, we're connected with the schools, the emergency departments, and the police, but we outreach to all kinds of folks in the community to make them aware of the service. We want to make sure that folks know about the service and make use of it, and that it's a rapid response service to help any child in need. So, and as we've indicated, we're responsive to schools, emergency departments, the police, foster families, anyone who needs the emergency service. And we establish really high criteria for providing quality service, and I'll get into that in a moment. We do work closely with emergency departments. We actually have initiatives. In some cases, there are collaborations with emergency departments where we work with them. If a child comes in and the emergency department really isn't staffed and equipped to work with kids with behavioral mental health issues, they will ask us to come in and work with the child, or they'll just call us to come in, even if they don't have an agreement with us. So we work very closely with the emergency departments. And one of our primary goals, as was cited earlier, is to provide a diversion to the emergency department. All of us who've been to emergency departments one or more times in our life, we know that it can be somewhat of a stressful, time-consuming event, and that's for those of us as adults. It's even more so overwhelming for children and potentially traumatic. So we want to divert kids going to the emergency department. So we work very closely to do that. We have a lot of initiatives to do that. And we also work to reduce the inappropriate use of inpatient care. That's obviously linked to our trying to reduce the use of emergency departments. As already cited, we work to reduce police involvement and arrests. And we work, really, the whole service works to provide a consistent response with improved accountability. And so what does that mean, improved accountability? I've kind of referenced already the benchmark that we have for being able to respond to calls within 45 minutes at least 80% or more of the time. We also have a benchmark where we expect our mobile crisis teams to respond to at least 90% or more of the calls that come in from 211, which means going mobile. We have a very high expectation for our teams to go mobile as much as possible, and we've exceeded that 90% benchmark for a number of years, so that's not been a problem.
The other important thing I want to add is wherever you are in the state of Connecticut, we want the service to look the same.
Yes.
So that's why the benchmarks are so important, and that we all have common practice around the goals and the implementation of the service.
This is a very important piece of what Mobile Crisis does, particularly because children can go to school in a different area than they live. And because the service mirrors from one area to another, they're also easily able to pass from one area to another and have the service continue just as it would from the initially responding team.
Now, we can say we want to provide a consistent response across the state, but there has to be systems and mechanisms to be able to kind of say, yes, we're doing that. So we are kind of uniquely positioned, Mobile Crisis is, that since 2009, we have something called a Performance Improvement Center, PIC, that is actually our quality assurance, quality oversight branch of our service. They collect data. We have data on everything that we do, from how much time it takes to get somewhere, to whether a child has had a trauma history, to a demographic history, to a variety of other things. We have an enormous amount of data. All that data goes to the Performance Improvement Center, and they generate reports to tell us what's working, what's consistent, what's not consistent, and where we may need to make improvements in the system. And it's a very important service that we have that a lot of services really in the state aren't benefiting from. They don't have something like that in place. And that service is provided by the Child Health and Development Institute of Connecticut. So as you can see, we have a lot of pride in our mobile crisis services. We feel it does a superb service for children and families and the community throughout Connecticut. And we are very much appreciative of your participating with us today to get some more information on mobile crisis. So thank you.
Thanks so much, Arnie, Amy, and Sarah. That was a fantastic overview of a really important statewide service. So thank you for that great overview. And thank you to everyone that's tuned in today. At this time, we'd like to open it up for questions. And everyone on the webinar is in listen-only mode. So if you can go ahead and hover over your control panel, you'll have the option to type in questions in our Q&A box. And we will do our best to answer those questions live on this webinar, or make sure we follow up with you individually to answer your questions. Once again, if you go ahead and hover right over your control panel, you'll see the option for Q&A. You can click on that option and type in your question in the question and answer box. So the first question we have is, will these PowerPoint slides be emailed? That's a fantastic question. Everyone that registered for today's webinar, whether or not you logged in, will receive not only a copy of the slides, but a link for this recorded webinar. We are recording the webinar. You'll receive that link. It will also be made publicly available on 211ct.org. So I'll make sure that I follow up with all that information. Thanks for that great question. So if there are no additional questions right now, we're going to go ahead and finish up the presentation. I will just jump quickly back in to our slideshow. And this, once again, will be emailed to everyone, but this is a list of youth mobile crisis providers across the state. In addition, we have some helpful links with more information about mobile crisis intervention services, including a link to the Performance Improvement Center, which Arnie talked about, where there's some really great data about the quality of this service. So if there's no further questions, thank you again, Arnie, Amy, and Sarah, and thanks to everyone that tuned in today. Once again, this is the first of our winter webinar series. The next webinar will be on Tuesday, February 16th, and focus on the Fatherhood Initiative. Thanks so much and have a great day.
Thank you.
Thank you.
Thank you.